Hello, my name is Mark Brown, and I'm a pediatric pulmonologist at Children's Hospital, Colorado. I, along with two of my colleagues at the Breathing Institute, Bill Anderson and Meghan Camacho, will be explaining the three main steps to managing severe asthma: identification, which I will cover; evaluation, which Bill will cover; and adherence, which Meghan will cover. As you know, asthma is the most common chronic disorder of childhood, impacting somewhere between 7 and 12% of children at any given time, depending on age and other factors. Most of these children can be effectively managed with guideline-based therapies. However, about 5% of children with asthma have problematic, severe, persistent asthma. These children have symptoms and/or recurrent exacerbations despite maximal conventional therapy, in contrast to children with controlled or non-problematic severe persistent asthma, whose asthma can be controlled, albeit with higher levels of therapy. They are not currently identifiable by any current biomarkers. Maximal medical therapy is defined as GINA steps 4 or 5, or NHLBI steps 4, 5, or 6. In essence, any child who cannot achieve control with medium-dosed inhaled corticosteroid plus long-acting beta-agonist is considered to have problematic, severe, persistent asthma. These children seem to fall into endotypes that can be distinguished by age: preschool, school-aged, and adolescent. Preschool children with problematic, severe, persistent asthma tend to have onset of their asthma before 24 months, atopic dermatitis, and aeroallergen sensitization. Problematic severe asthma in school-age children is associated with evidence of air trapping on pulmonary function testing, bronchial hyperreactivity, increased bronchial smooth muscle on biopsy, and both peripheral eosinophilia and elevated fractional excretion of nitric oxide. In adolescents, this asthma endotype is marked by chronic airflow obstruction on spirometry, a marked methacholine response, and waning reversibility following beta-agonist. In addition, studies involving airway biopsies in this group suggest that there may be early airway remodeling. Before concluding a child has problematic severe asthma, one needs to exercise due diligence. This includes treating common comorbidities that may impact asthma control, such as allergy or reflux; advising families in environmental remediation, including allergen reduction and environmental tobacco smoke avoidance; truly optimizing guideline-based care; and confirming adherence. We'll hear more about that later from Meghan. If these steps are taken, and the child persists in having poor asthma control, marked by frequent need for albuterol, systemic steroids, urgent care or ED visits, and/or hospitalization, a referral to the multidisciplinary asthma clinic may be appropriate. This will be discussed in detail later by Bill. Occasionally, other illnesses will masquerade as asthma. Some of these include cystic fibrosis, primary ciliary dyskinesia, aspiration, and others. The comprehensive evaluation in multidisciplinary asthma clinic is focused on excluding these, assessing patient and family needs in terms of treatment, education, and other support, and achieving control before returning asthma management to the primary care provider.
My name is Dr. William Anderson. I'm an Associate Professor of Pediatrics and Co-Director of the Multidisciplinary Asthma Clinic. A patient's asthma may be poorly controlled due to complicating comorbidities, or these comorbidities may mimic asthma symptoms. Common comorbidities we encounter during our workup for difficult-to-treat asthma include allergic rhinitis, sinusitis, vocal cord dysfunction, also known as inducible laryngeal obstruction, gastroesophageal reflux disease, obesity, sleep apnea, eczema, food allergies, secondhand or direct tobacco or marijuana exposure, and psychosocial factors. Addressing and treating these comorbidities can improve asthma control and potentially prevent unnecessary escalation of asthma controller therapy. I would like to highlight a few of the common comorbidities seen in difficult-to-treat asthma which we encounter. The first comorbidity is environmental allergies. In Colorado, we are exposed to outdoor aeroallergens from March to October and indoor allergens all year. A study of children with asthma found that at least 88% were sensitized to at least one aeroallergen, and over half were exposed to at least one indoor allergen in their homes. As such, the most recent asthma guidelines recommend testing for aeroallergen sensitization and then mitigating exposures to these allergens if they are found to be allergic. Inducible laryngeal obstruction is another comorbidity. ILO, as it's also known, is a paradoxical adduction of the vocal cords during inspiration. Like asthma, ILO can result in symptoms of shortness of breath and can be brought on by exercise. However, there are key features that distinguish it from asthma, including a more precipitous onset and resolution, lack of symptoms with sleep, and a sensation of throat tightness. The treatment involves exercise directed by speech-language pathology. Obesity is another comorbidity. Obesity can directly impact asthma control, but also mimic asthma symptoms through deconditioning, which will occur during exercise. Obesity is associated with increased asthma quick reliever use, controller therapy use, and exacerbation risk. In addition, obesity is associated with increased airway inflammation and an impaired response to inhaled corticosteroids. A final comorbidity is secondhand or direct tobacco or marijuana exposure. Secondhand tobacco smoke is associated with an increase in unscheduled healthcare visits, oral steroid use, and a more rapid decline in lung function. Beyond being an irritant, tobacco smoke exposure reduces the efficacy of inhaled corticosteroids, all of which may lead to a need for higher doses of steroids.
Hello, my name is Meghan Camacho. I'm the Operations Coordinator of the Multidisciplinary Asthma Clinic at Children's Hospital, Colorado. The NHLBI Expert Panel Recommendation Guidelines suggest checking adherence and inhaler technique when assessing control and before escalating controller therapy. Studies have shown that less than 50% of patients use appropriate technique when taking inhaled medications. Poor inhalation technique can lead to poor asthma control because the medication is not adequately delivered to the lungs. Technique should be reviewed if a patient's asthma is not well controlled prior to escalating therapy. We have videos available through Children's Hospital Colorado YouTube channel that highlight appropriate techniques for inhaled medications. In addition, we offer the annual Asthma Educator Certification course known as Reach the Peak. A family's ability to take medication as prescribed by their medical provider is crucial to disease management. However, medication adherence is difficult to evaluate and influence. Factors to consider when assessing adherence include family's priorities, amount of social chaos in the home, complicated or unpredictable schedules, medication beliefs, health literacy, access to medication, and parent involvement or lack of involvement in medication management. We know it is nearly impossible for families to be 100% adherent 100% of the time. In order to improve a patient's adherence, it is important to set realistic short and long-term goals that are attainable for the family. If a patient is currently taking 25% of their prescribed medication, it is unrealistic for the care team or the family to expect 100% adherence in 1 week. Instead, try using motivational interviewing techniques by asking what changes the family can make. Ways to assess adherence are: call the pharmacy to check on refills, provide a weekly calendar for families to track medication, track the number on the inhaler's counter, utilize asthma or habit tracking apps available for smartphones, or simply help families set a timer on their phone to remember when medication should be taken.
Children's Hospital Colorado offers the Multidisciplinary Asthma Clinic for pediatric and adolescent patients who remain poorly controlled despite guidelines-based treatment. The Multidisciplinary Asthma Clinic, also known as MAC, is staffed by a team including a pulmonologist, allergist, nurses, physician assistant, social worker, dietitian, and speech-language pathologist. MAC's mission is to empower patients with asthma and their families to invest in their health management by providing innovative multidisciplinary care based on patient-provider collaboration. We recognize that each patient faces unique challenges and deserves unique care. With each clinic visit, patients and their families will leave feeling accomplished and confident in their ability to make decisions to help control their asthma and meet their goals. Patients in MAC receive a personalized evaluation based on their prior history and diagnostics. During each MAC evaluation, patients will see our pulmonologists and allergists and receive extensive education by our nursing team. Most patients will see our social worker. Social work specifically works to address the psychosocial barriers to care that can affect asthma control, including missing appointments, insurance and cost barriers, and mental health. Speech therapy and nutrition will be involved if the team identifies the need during our initial evaluation, with the ability to address ILO and obesity respectively. Workup will include spirometry, labs, and allergy testing. Outside of the clinic, our nurses work extensively with our patients and their families. They address prescriptions, reinforce education, and facilitate additional workup, as well as communicate with schools and primary care providers. In MAC, we offer use of electronic medication monitoring devices to monitor adherence in real time. These devices allow providers and families to track both controller and rescue medication use. Knowing patterns of medication adherence allows our team to tailor treatment regimens for our patients. For example, we can recognize poorly controlled asthma symptoms, we can recommend a once-daily controller therapy, or we can address root causes for barriers to care. The approach MAC takes has been associated with reduced hospitalizations and emergency room visits. We have also reduced asthma-related costs. You may want to consider MAC if your patient meets any of the following criteria. A patient has poorly controlled asthma despite guidelines-based therapy, unscheduled healthcare utilization for asthma, including PICU admissions, hospitalizations, or emergency room visits, recurrent oral corticosteroid courses for asthma, multiple comorbidities directly contributing to poor asthma control, a diagnostic evaluation for asthma, or there's an unclear diagnosis, consideration for biologic treatment, and finally, requiring multidisciplinary services such as social work, nutrition, or medication adherence monitoring.
Thank you for joining us today. I hope that Megan, Bill, and I have been able to add some clarity to you around severe, problematic, persistent asthma in children. If you have any questions, please go to our website or feel free to reach out to us at the number provided on the screen. Thank you.